I will start our slides. So as she said, I'm Dr. Gretchen Garofoli. I'm a faculty member in the School of Pharmacy. And I have two of my esteemed colleagues, Dr. Krista Capehart and Dr. Lisa Costello, both on with us today as well. So hopefully we'll be able to answer any and all questions that you may have. Since we're short on time, we'll jump right into the presentation. I'm going to give a quick overview of the bivalent boosters that are currently available. And then Dr. Krista Capehart will jump into answering some of the most commonly asked questions that we receive and going over the data to support the answers. So with regards to the bivalent boosters that are now available, in the fall of 2022, so the fall that we are currently in, there was really a reset that happened with the boosters. So we know that patients had received boosters in the past. Many of us had received boosters in the past. And this is continuing to provide a lot of confusion for us and for the patients that we serve. So the change went from counting different doses and saying, okay, this age group was eligible for a certain booster to now everybody is eligible for a bivalent booster, depending on their age, so 5 years of age and older. And so we really need to, I think all of us as healthcare practitioners do a better job of educating our patients. I went to a clinic a few weeks ago and I had people that wanted to get boosted and their colleagues and friends said that they left because they hadn't gotten the original booster, so they didn't think they were able to get this booster. Well, that's not the case anymore. So all that we need to do is we need to have a patient complete their primary series, let 2 months pass, and then they're eligible for a bivalent booster dose. And yes, we do still have folks that are finishing up their primary series. And so that's really important for us to look and still see when patients completed their primary series or when they last received other doses prior to giving them the bivalent booster. The bivalent booster has been out long enough now that we're not as concerned with when patients received the original boosters, but really looking at the primary series to make sure that patients completed that. And then we let 2 months lapse before we give them that bivalent booster dose. But all of these groups are now eligible for bivalent boosters as long as it has been 2 months. And so first we'll talk about the Pfizer-BioNTech Omicron or the bivalent booster for ages 5 through 11. And then for those 12 and older, this is the product that we have. And so when we're looking at the different products available, we will have the products with regards to bivalent in red boxes, so it calls them out on these slides. And so you can see the monovalent here compared to the bivalent product. And if you are administering them in your clinics, it's important to keep in mind how similar these products look. If you have any of the monovalent product in your areas, to be sure that you are administering the bivalent dose as appropriate and the monovalent dose as appropriate to patients as well that are still doing the primary series. And so having double checks in place is extremely important to ensure that patients are getting the correct vaccine. And so the bivalent product for those 12 and older, these are, again, authorized as booster doses. They are gray in color when you're looking at the vial. And it does have 30 micrograms in it, 15 micrograms of the original, and then 15 of the Omicron, and that's specifically the BA.4 and the BA.5. The injection volume is the same, so 0.3 milliliters. So we were used to drying that up for the monovalent product. Same for the bivalent product. The Pfizer products no longer for adults require dilution, so that's important to keep in mind whenever you are preparing these products. They are good for 12 hours after puncture, and the storage requirements are included on this slide. So the ultra cold freezer until expiration, or the refrigerated temperatures up to 10 weeks. And as we move into talking about the Moderna doses coming up, just keep in mind the differences between the products so that you have a process in place to keep in mind how long those products are good at the refrigerated temperatures. And so looking at the booster doses for those 5 to 11 years of age, we have the monovalent listed here as well as the bivalent. And you can see that they're orange for both products and what is included in each of those. So 10 micrograms in each of those products. The bivalent does have the Omicron as well as the original. Same injection volume. This product does require dilution, so keep that in mind whenever you are preparing the doses for these patients. And so looking at the products for the kids that require the dilution, each vial must be diluted before administering that vaccine. Again, we want to do anything and everything that we can to prevent vaccination errors. So the bivalent vial contains that frozen suspension that does not have a preservative, and the vial must be thawed before dilution. So ensure that those get to room temperature before you start to prepare them. So use the normal saline. It's not included with the shipment of the vaccine. So make sure that you have the appropriate normal saline, the 0.9%, to be utilized for diluting this vaccine for these patients. After it's diluted, one vial does contain 10 doses of the 0.2 milliliter doses for these patients. And again, if you're vaccinating both kids and adults, ensure that you're preparing them correctly and have the proper amount drawn up. And so we'll move on to Moderna now. And so this booster is available for those 6 years of age and older. And so when we're looking at the different products, so you can see the 3 products listed here, we did include the purple one on this slide because that is still in circulation and it does say booster dose only, but this was for monovalent booster doses. And so it is not utilized for the bivalent booster dose. So that can provide some confusion whenever we might have it in our clinics. And so really looking for the words bivalent product or bivalent booster on the label prior to preparing doses when patients are coming in for the bivalent boosters. The bivalent product, it is dark blue. It has a gray border around the label, and it's 50 micrograms for the booster dose, 25 of the original, and then 25 of the Omicron, a half a milliliter for this age group. It does not require dilution beyond use date, so 12 hours once that's punctured. And this is where we need to really keep in mind the differences for the temperature. So this is kept in the freezer until expiration, and then the refrigerator up to 30 days, whereas the Pfizer product was 10 weeks in the refrigerator. So again, having a system in place to check for that to ensure that you are utilizing products before they expire. And so this is, again, the bivalent product, just calling it out here when compared to the monovalent product so that we know the differences whenever we are preparing those and providing those to our patients that are 18 years of age and older for the bivalent. And so for the kiddos, so those 6 to 11, we do have the dark blue vial cap. It's a gray and color around the label, like we mentioned, and the doses are different for the younger kiddos versus the older people. And so just keeping in mind the dosages whenever you are preparing them for patients for clinics. There's no dilution required, again, for this 12 hours, same as it is for the Pfizer for once you puncture it and time to utilization. So again, these are just a review of all of the available information for these products. And then with regards to highlights, so this might be a good slide to keep somewhere to refer back to the fact sheet. And this has been something that has arisen time and time again in practice. People are asking about the differences between the fact sheet and the vial and the carton label. So we know that the fact sheet is the most up-to-date information that we have and that we can provide to our patients and provide to ourselves as clinicians when we're reading over information about the vaccines, because the vial and the cartons, they may have been in distribution for some length of time. And so to make sure that we are referring back to the most up-to-date information, that would be coming from the fact sheet. So always download the most up-to-date fact sheet, check regularly to ensure that there are no updates so that you're referring back to the most up-to-date information. You cannot refreeze the vials once they are thawed. Each multiple dose vial contains 5 booster doses for the older folks. So that would be the 0.5 milliliters, or 10 doses for the younger people, which is the 0.25 milliliters. So that's the 6 to 11-year-olds. And so one thing to keep in mind for all of these vaccines is that if the amount of the vaccine remaining in the vial cannot provide a full dose, discard the vial and the contents. Do not pull excess vaccine from multiple vials to get a full dose. Only utilize that one vial and utilize full doses from it. And so again, just a reminder for Moderna, you do not need to dilute it prior to use. Make sure that you are just pulling it straight out of the vial. And so again, the temperature information, the frozen storage, and the storage after thawing, we've already reviewed that. So just something to kind of keep in mind as you are moving forward. And so without further ado, I will turn it over to my esteemed colleague, Dr. Krista Capehart, to go through some of the clinical considerations that we need to think about when we are providing answers to our patients and when we're getting those hard to answer questions.
Thank you, Dr. Garofoli. Great job as always. So good afternoon, everyone. I want to share some of the things that may come up as you're working with patients. So keep in mind, we could be talking about all of our labels on these bottles will say bivalent, but patients, we know that they are a little averse to the word bivalent. They don't know what it means, those kinds of things. So while as healthcare providers, we'll refer to it as bivalent, when we're talking to our patients, probably want to use updated booster, Omicron booster, as more layperson language friendly. So I did want to include these slides. These are the very simplified schedules for COVID vaccination. So your ages 6 months through 4 years, you'll notice vaccinated with Moderna or Pfizer. Neither of those populations are eligible for any type of a booster at this point. Ages 5 years through 11 years, if they are vaccinated with Moderna, with Moderna or Pfizer. Remember, Pfizer starts at age 5, Moderna starts at age 6. They would complete their primary series, wait 2 months, and then be eligible for the bivalent or Omicron booster. Now, starting at age 12, we do have 3 options. They would be eligible to get either Moderna, Pfizer BioNTech, or Novavax. That has just recently been authorized down to age 12. And then after 2 months, they would be eligible for that bivalent messenger RNA booster. And then finally, for those who received a Janssen or J&J primary series dose, they would wait 2 months and then get a bivalent booster. So moving on then to our patients who are considered moderate to severely immunocompromised, the schedule changes a little bit differently, 6 months through 4 years. Again, no boosters authorized, but you'll notice that both with Moderna and Pfizer, they do need 3 doses to complete their primary series. Ages 5 through 11, 3-dose primary series, waiting 2 months, and then getting that bivalent booster. Then ages 12 and older, again, you'll notice 3 doses for primary series, wait 2 months, and then getting that booster. Then with Novavax, a 2-dose primary series, wait 2 months, and bivalent booster. If they're 18 and older, they would have a J&J, then an mRNA booster after 4 weeks, or an mRNA dose, and then 2 months, and then a bivalent booster. One thing about this immunocompromised population that we do want to stress is that we do have monoclonal antibodies for pre-exposure prophylaxis. These are not used to treat once they have contracted COVID, but rather when they are COVID negative, to assist and keep them from contracting COVID. This is Evusheld. And while we are hearing more and more that Evusheld may not be protective or effective against some of the newer variants that we're seeing at this time, it is still part of the treatment, or part of the prevention and toolbox recommendations in our immunocompromised population. So we would still want to vaccinate this population, then wait 2 weeks and give them an Evusheld dose. They do get Evusheld every 6 months to help as part of that prophylaxis regimen. So here's just a bigger picture of that. We do have plenty of Evusheld readily available. So make certain that if you have these moderate to severely immunocompromised patients, that you are recommending that they seek this Evusheld pre-exposure prophylaxis, because it certainly is that other tool in the toolbox that can help this population. So here's one thing that I really want to stress. We're hearing all different kinds of things across the, that practitioners are recommending, but it truly is best practice for routine administration of all age-appropriate vaccines at the same time, unless they have some sort of specific contraindication. So we should be giving the flu and COVID together, without regard to timing of other vaccines. I tend to explain it to people that we know they're going to feel a little crummy when they get flu. We know they're going to feel a little crummy when they get their COVID bivalent booster. Let's give them the same time, and then they only feel crummy once. But it is considered best practice to go ahead and give those once, and give them together. The only exception there is with monkeypox, and there are some additional considerations. So we recommend that you go to interim clinical considerations for COVID, and they'll discuss those. So always offer that influenza vaccine and COVID at the same visit. You can do them in separate limbs. You can do them in the same limb, separate them by an inch. So just a few other things. It is recommended for everyone ages 6 months and older to stay up to date on your COVID vaccines. Remember, primary series at this time are done with the monovalent. And then for ages 5 and older, everyone is eligible for a bivalent updated Omicron booster. Anticipated side effects really haven't changed. Very similar throughout all of these vaccinations. Local, we got pain, swelling, redness at the injection site. Systemic, maybe see some fever, fatigue, headache, chills, arthralgia. I will say we're seeing some lymphadenopathy, particularly under the arm, on the side, often on the side where the injection was given. So did have a few questions that I wanted to kind of address. What has been the mortality, or what is the mortality that we're looking at right now for COVID? One of the ways that we are seeing mortality addressed right now is that looking at it from a case to fatality ratio, and that's why you get this wide spread. So death to the number of cases, because of course positive cases, because of course then the more times people test, that's going to adjust your denominator. So if you look at this slide, you can see, of course, Peru had a much higher mortality percentage than other countries. So keep that in mind. Some countries have done much better with actually managing those cases than others and the treatment. So did want to actually go ahead and present that. So I always get lots of questions, and especially with these bivalent boosters. I will tell you that as a whole, these COVID-19 vaccines have absolutely been studied more than probably any vaccine to date. To have vaccination studies that were done on more than 40,000 patients before a vaccine ever reaches the market is almost unheard of. There was a lot of question when the vaccines came out because people thought they hadn't been studied. That was absolutely false. We hardly ever see vaccines that had been studied on this many people. So then, which should have given us lots of confidence in these vaccinations. Then when we got to the bivalent, they did the studies a little bit different. What they did was in January of 2022, they started testing a bivalent. What it was the original Omicron, and the second strain was a BA.1. So they started testing that, and they got that data back, and FDA and Advisory Committee on Immunization Practices reviewed that in June. In June of 2022, they made the decision that they did want to proceed with a bivalent or containing 2 strain vaccine for the fall. But what they wanted to do was actually update it to have the most recent variants. And so they proceeded to do an original strain with BA.4 and BA.5. So very similar to what we do with the flu shot every year, where we update it to the strains we think are going to be most prevalent. That's exactly what they did with this updated Omicron booster. They said, you know what? We know BA.4.5 are going to be our most prevalent variants. So instead of BA.1, which we tested, let's put BA.4, BA.5 in. And the reason it's .4.5 is because the information for both of those is exactly the same for the spike protein. So the exact same genetic information, messenger RNA, is exactly the same for both of those. So so they did study both of them, and had a substantial increase in neutralizing antibody response above pre-booster levels taken 7 days after administration. They saw similar responses in ages 18 to 55 when this was with the Pfizer one, when they gave a 35 microgram dose. What they did, they compared the original, and the original elicited a much more limited increase in the neutralizing response against the BA.4 and BA.5 variant. And so that was the data that they ended up looking at for that authorization. So if we look at the Moderna data, very similar thing. So our it was a 50 microgram bivalent versus a 50 microgram original. Again, the data they looked at was an original and BA.1, and the bivalent elicited a superior neutralizing antibody response against Omicron compared to the monovalent booster dose. And that's when the FDA and Advisory Committee on Immunization Practices said, yes, absolutely, let's do a bivalent, but instead of BA.1, we want to do BA.4 and BA.5. So I also often get the question of, you know, everybody says we're supposed to get vaccinated, but people are still getting COVID. So what does it really matter? Yes, it absolutely matters. First and foremost, the COVID vaccines were not designed to prevent contraction of COVID. They were designed to prevent severe infection, hospitalization, and death. Okay, so and absolutely they're effective in doing that. What we have discovered, though, is that they are also effective in preventing the complications of long COVID. There was an initial study from United Kingdom that came out in 2021 that indicated potentially a reduced risk of long COVID by as much as 41%. Now, there have been a couple of just really enormous studies that have come out since then that have not indicated that the reduction is as high as 41%. There was a U.S. Armed Forces study that showed you were about 15% less likely to experience long COVID if you were vaccinated than those who were not vaccinated. So what does that mean for us? The symptoms and consequences of long COVID can be incredibly debilitating. Neurological deficits. I mean, there are people that are truly unable to function, memory fog, perpetual long complications. So if you're able to reduce that likelihood, definitely better to go ahead and get vaccinated. So also had some questions about, well, we've heard especially about the risk of cardiovascular complications with the COVID-19 vaccines. So how does that compare to the cardiovascular risk with COVID? Well, let me tell you, it's not even in the same ballpark. So wanted to pull this. I pulled this up from a pretty recent, I think it was published this past summer. They actually looked at the risks and 12-month burden of post-acute COVID-19 composite cardiovascular outcomes. And so you can see they looked at cardiovascular disorders, dysrhythmias, inflammatory heart disease, ischemic heart disease, other cardiac disorders, clotting disorders. And if you take a look there, you can see any cardiovascular outcome in terms of ending up in an ICU or hospitalized. You were looking at close to, an excess burden of 300 per 1,000 persons, 180 per 100,000 persons. So, it's not like, it's a big risk. Seeing some pretty major cardiovascular complications with COVID itself. And just anecdotally, the number of patients who experienced near asymptomatic COVID, but then have severe cardiovascular complications post-COVID is pretty major. So now let's talk about the COVID vaccines itself. So the cardiovascular risk that we saw was primarily with the Moderna vaccine, but the warning does fall with both of the messenger RNA, so Moderna and Pfizer. And the incidence was seen mostly in the 12 to 39-year-old male age group. And after significant evaluation, the incidence of cardiac outcomes after a messenger RNA COVID vaccine, it was highest for males, specifically in that 12 to 17 age group after that second vaccine dose. However, within that demographic, the risk for cardiac outcomes was still 1.8 to 5.6 times as high as SARS-CoV infection than after the second vaccine dose. So you're way more likely to experience cardiac events after infection than after your vaccine dose. So still much more likely to get complications from the infection itself than from the vaccine. So we've gone over a bunch of the questions that were provided to us. And, the other thing that I actually didn't put any slides in, but I know that we were asked to talk a little bit about, is the extension of the public health emergency, or when it may or may not end. And then what's going to happen with the vaccines and coverage of those and those kinds of things. So we actually did just find out that on Friday, this past Friday, that the public health emergency will be extended into April. So we know that it will go through April 11th of 2023. And so we don't anticipate, the information that I'm getting is that we don't anticipate that these COVID vaccines will hit the commercial market probably until next fall, meaning that they will be available free to the United States population, through this fall and all through the spring through the summer. So we don't anticipate that we'll get more COVID money, but that the volume of vaccine that has been purchased at this point will continue to be provided to the American population for free at this point. But once that money is spent, and when the public health emergency ends, which we anticipate will be in April, but you never know, it could get extended for another 3 months. The federal government does have to renew that every 90 days, and they have to let the states know at least 60 days before it's going to expire. So they would have to let us know by February 11th if they were not going to extend it. These vaccines will hit the public, will go into the commercial market. And right now what we're hearing is that these will probably be about $110 to $130 a dose. And we know that, flu is right around $30, $40, and we don't have great uptake of flu, even for patients that have insurance coverage. We do know that the Advisory Committee on Immunization Practices added the COVID-19 vaccine as a recommended vaccine for all ages for 6 months and up. So that will make it a covered vaccine for third parties, but we'll just have to see how it not being free impacts uptake. So I think we have quite a few things that are coming. We've already seen that the lone monoclonal antibody for treatment, bebtelovimab, has already entered the commercial market, and it is about $2,300 per dose. Insurances are covering it, but patients are left with a significant copay. Right now, Paxlovid, molnupiravir are available, are still available, government funded, but as the money runs out, those two will go into the commercial market. And so there's a lot of steps that have to happen. The company has to decide if they're going to pursue full approval on those products. Is there going to be a market for them? All of those kinds of things. So we do have quite a few steps as we start to unroll those things. So Gretchen, we have a question about the purple, brown, and green on the previous chart. So going back to so you can't really read it, but if you go, the green is actually non-hospitalized, all-cause mortality. You have the red is hospitalized and the purple is ICU. So those were burdens of incidents in those various categories. The code, the key is down there in the very bottom. Sorry, it's really small to see. But I did want to throw that slide up there so that you could kind of get an idea of where it was. So I think that's all the information. We were asked to give about 25-30 minutes. And I think we threw a lot at you. I want to open it up to Dr. Costello and see if she has anything that that Gretchen and I have left off that she wants to add. She's always fabulous at throwing everything, at catching all the things that I've forgotten. Nope, she says all good from me. So I'd like to open it up to questions for anything that you guys specifically have.
Well, first and foremost, thank you both so much. That was a lot of great information. And I will say we're going to attach it in our recap email. So everyone beyond even who's joining today will be receiving those slides. So thank you. But yeah, any questions from anyone, feel free to unmute. You can raise your hand or you can chat in. Jen, I saw you put your video on. Did you have a question or comment?
No, I submitted a lot of questions prior to on behalf of the chief medical officers of the federally qualified health centers through the West Virginia Primary Care Association. You guys covered everything. So I really appreciate it.
Absolutely. I would assume those are probably the questions that were forwarded. And I was like, oh, I know where all of those are. I just have to go and pull them.
You did an amazing job. Thank you.
Oh, well, thank you so much.
And thank you, Jen, for sending me those questions. It was all so great. And I'm sure everyone was wondering those questions as well. So we appreciate you submitting those. Any comments, questions from the group? And if after the fact you think of any questions, you can always shoot us an email as well. We'll make sure to have them addressed.
Yeah, and I would say, you know, we have the social media press kit and the toolkit, the provider toolkit that have been put together. Those have so many tools for providers, answer so many questions. Those are available and just incredibly helpful for providers and are updated regularly. And then of course myself and Gretchen and Dr. Costello are always available, and if we don't know the answer, we usually know exactly where we can find the data to get you the answer.
Thank you so much, Dr. Capehart. And that's a really good skill to have too. Even if you don't know the answer, you know where to go.
That's my favorite. That's my favorite skill. Otherwise, I'd be in serious trouble.
I know, me too. I love it. And if there's anything further, I know you guys had a lot of great resources and information in there, but if there's anything else you want to email me, I'm more than happy to add that in the recap email as well.
Sure.
If there are no further questions, another big shout out and thank you to you both for joining us today and putting together such a wonderful presentation on short notice. We really appreciate it a lot. So thank you both very much. I don't have any announcements. I will just say that these are a pop-up session now, so they're not technically scheduled consistently. We just sort of host the sessions if there are questions or if there's something pertinent that we need to discuss related to COVID. So any further questions or topic requests in the future, you can always email both Elizabeth and I, and we'll make sure to, again, we'll go find the proper place to go and find the speaker for it. So thank you all so much. We really hope you have a wonderful Thanksgiving and holiday season. Stay warm. Dr. Capehart, I hope you get home safely and get to rest up well.
Well, thanks so much. And thanks so much for having us as well. We really appreciate it.
Absolutely.
Thank you.
Thank you, Dr. Garofoli and Dr. Capehart. Thank you all. Take care.
Bye, everybody.
Okay.